Welcome, everyone. I'm Maureen O'Connor, president of Palo Alto University. It's a pleasure to welcome you to our webinar series, At the Forefront of Mental Health. Palo Alto University is dedicated to addressing pressing and emerging issues in the fields of psychology and counseling that meet the needs of today's diverse society. Today's discussion, Burnout and Compassion Fatigue, a crisis among healthcare workers, couldn't be more relevant. According to a recent article in The Lancet, under typical work conditions prior to the pandemic, severe burnout syndrome affects as many as 33% of critical care nurses and up to 45% of critical care physicians. The trauma of caring for patients who are critically ill have been heightened by the COVID-19 pandemic and represent heightened factors for poor mental health among healthcare workers. Today, our expert panel will take an inside look at this pressing mental health issue. Now it is my pleasure to introduce today's moderator, Jorge Ortiz. Mr. Ortiz is a breaking news reporter for USA Today. We're delighted to have him with us. For the past year, he has covered the pandemic and the toll it has taken on healthcare professionals. Jorge, thank you so much for moderating this important discussion.
Thank you, President O'Connor, and thank you all for being here today. The topic of burnout and compassion fatigue is not new to healthcare professionals, but it has reached epic proportions during the pandemic and can lead to serious mental health consequences. Our panelists will explore this topic and offer special insight on the impact it's having, the culture in which it exists, prevention, treatment, and possible solutions for minimizing its occurrence. Before we begin, I have a couple of housekeeping items. This discussion will be recorded and a link will be sent to you within a week. We will leave time at the end for questions. Please use the Q&A function at the bottom of your screen to submit a question. Please note if your question is for a specific panelist. Finally, please check the chat function for details about receiving CE credit. You cannot receive credit if you're on a mobile device, so stay around your computer. And now, allow me to introduce our experts. Joining me today are Matthew Cordova, who's a clinical psychologist and a professor at Palo Alto University, where he is also co-director of the university's Early Intervention Clinic. Christoph Kimmler is an assistant professor of medicine at Stanford University School of Medicine. He's also a practicing psychotherapist and founder of Resilience in Healthcare. And Karen Roller is also a faculty member at Palo Alto University. She's a clinical traumatologist and compassion fatigue therapist. I'd like to start with Christoph as we address the problem of burnout. What exactly is burnout among the healthcare providers, and how is it manifested? How do you recognize the problem, and what steps can you take to address it? Christoph is particularly well suited to talk about this because he dealt with the problem himself.
Yeah, so thanks for the question. I think in talking about my experience, I thought I'd start with before I was burnt out. So about 20 years ago, I was finishing my residency at Stanford in internal medicine, and I did a year called a chief residency year where you stay and you teach and you do a lot of clinical work. And at that point, the term hospitalist had just been coined by some UCSF physicians, and it was a new sort of a nascent specialty that involved taking care of hospitalized patients. So not hypertension in the office or high blood pressure as people admitted to the hospital. And so after that year, when I was asked to come to the Palo Alto VA to start their hospice program, I was incredibly excited. And in the first 5 years working as an inpatient, as a hospitalist at the VA, it was a great job. It was exciting. There was 2 to 4 hours of teaching a day, large groups, small groups at the bedside. We had there were teams, so you worked with trainees and mental health people and pharmacists. That was really rich. And you worked interdisciplinarily, so you would have discussions with surgeons or psychiatrists and talk about the patients. And with the Stanford residents, a great, great bunch of professionals, I remember really feeling like clinically we were giving people the best care in the world. I remember really feeling this way, and feeling also that we understood the patients, that almost all of the patients that came through by the time they were discharged, we had learned about them, and we'd understood what was going on. And it was just a really sustaining feeling. And for all of us who teach, that virtuous cycle of teaching somebody who actually wants to learn is a very, very sustaining cycle. So over the next 5 years of my career, there were some changes that started that I think happened in a lot of healthcare systems. And I'll sort of stick with 5. There was an increase in the acuity of patients. So more and more patients had very high acuity. Patients who were less sick were dealt with as outpatients. So there was a distilling effect of patients in the hospital were sicker and sicker. There was a more and more documentation requirements, things that previously were we had to document more and more. A lot of nurses, a lot of other healthcare people. This trend was very, very significant. A lot of information, a lot of communication, email from patients. And then when we think about managed care, the big part of my experience was managed means you're competing for resources. So suddenly we were arguing and fighting, sometimes literally, for beds and for medicines and for nursing home beds. And this conflict was something that was very new. And again, sometimes we were even fighting with colleagues for ICU beds, let's say. There's a distinction, people who work in teaching and non-teaching hospitals. One watershed thing that happened to me in the VA, which is a teaching hospital, is around 2005, there were work hour limitations for residents. And so suddenly the whole workforce that was doing a huge amount of work could only be in the hospital for a certain number of hours per day or per week. And so this workload that was staying the same or growing, suddenly the workforce shrank significantly. And instead of the mentality being you stayed in the hospital till people were taken care of, suddenly everybody was looking at the clock. Literally, it became a shift mentality, which was a sea change, a complete change in the culture of medicine. So gradually, there was less and less emphasis on understanding what was happening and talking and teaching about it, and more emphasis on just moving people through the hospital. And that was a progressive thing. Until it sort of got to the point where the majority of patients that were discharged, I felt like I actually wasn't sure what had happened. I hoped I knew, I hoped we were right, I hoped they did well, but that sense of really understanding and knowing really deteriorated. And that sense of just doing a really good, complete job just got more and more sort of watered down. So in terms of my experience of burnout, there are a lot of things, but I want to also focus just on 4 or 5 elements that I think were key and are key for others usually, not always. One was just the fatigue. We would work month-long shifts, then 2-week shifts later on. And I noticed that where I would get tired by the end of a shift, end of 2 weeks, end of 4 weeks, I would get tired after a week, and then after just a couple days. And instead of bouncing back to feeling fine, it would take longer and longer to get to back to baseline. And then suddenly I would never really get back to baseline. I was constantly tense. There was more parts of the job that weren't critical I couldn't do. So documentation, things that were non-critical would just get delayed and would pile up. And I would start to have cognitive issues where a medicine that I knew how to dose the medicine for 15 years, I couldn't remember how to dose it. So I'd have to start to look it up. And I would start to have to check and double check things that I didn't ever have to check before. So that things became inefficient. The third part is what I think is best known as empathic distress. So when I came to work at the VA, one of the most powerful things was these folks had issues and I felt they deserved help, right? And so when they had a problem, you moved and you tried to figure it out. And I noticed early on, like I started if somebody was particularly anxious or particularly angry, I would start to sort of want distance. And this progressed to the point where I really just wanted to get, it's hard to say, I really just wanted to get out of the room as quickly as possible. And anybody that had any charge, any need, any anxiety, sadness, I just wanted to move away from it as quickly as possible, which is extraordinary to think about now. And it was not subtle, it was dramatic. The last thing here that I just want to mention is what I think different people hear in different ways, but these sort of patterned reactions that are sometimes known as fight, flight, freeze, and please. There are other words for them. And I would notice that I would start, these lenses would come up. So one day I might start to get angry and sort of end discussions quickly because I was frustrated or anxious. So anger would rise up to sort of close things off, close discussions or encounters off. Flight, in terms of flight, I would just start to avoid things. I couldn't do the documentation, so I would just leave it. And weeks of documentation would pile up, and I just wouldn't even think about it. The freeze is anxiety, and medicine used to be built on, you would argue, you debate. It was great, it was fun. And more I couldn't handle conflict. Right? Whether it was arguing about a course of action or arguing with a surgeon about whether somebody needed surgery, I couldn't tolerate it. I couldn't handle it. And so I would go along with things even if I didn't feel good about them, which was a terrible feeling. And I was watching myself do this. And then the please part also, just like whatever needed to get done, just so that there wasn't conflict, anxiety. And so from day to day or week to week or hour to hour, these different lenses would come in and sort of shape how I would react in ways that I couldn't really control. It was startling. So this led, the last thing just to mention is this sense of paralysis, because I'd been, even at that point of view, included education, I'd been in medicine for about 15 years. And I didn't feel like I could do anything else. And unlike a lot of physicians now who have massive debt, I did not have debt, but still the sense of just like, this is my only option was just overwhelming. The idea of doing something other than medicine was inconceivable to me. And so this whole thing just created what I think anybody would recognize as just a deep, deep depression, deep depression. And we'll wait to what I did about it later, but I just would say that I tried everything I could to get out of this, and ultimately went back to school for counseling psychology. So that's a brief cross-section of my experience.
It does sound like a lot of those symptoms are pretty classic displays of what you find for people who have experienced burnout. I wanted to talk to Karen Roller a little bit about how this might be different from compassion fatigue. Like you, she had firsthand experience with the issue. You know, the term compassion fatigue, to me, it kind of conjures images of a doctor or a nurse who doesn't care anymore for their patient and their suffering. But I'm sure it's more complex than that. And Karen has studied this issue extensively. Karen, can you tell us a little bit more about it and the difference between burnout and compassion fatigue?
Yes, thank you, Jorge. So the conceptual difference between burnout and compassion fatigue, the way that I talk with my students about it, is the difference between a repetitive stress injury and say in your wrist and carpal tunnel. So with a repetitive stress injury, we can have that with any kind of repeated behavior that's demanded of us in too much time to be able to then rest and recover from the demand. And some people will more quickly move into a repetitive stress injury with the same demands placed upon them because they had a pre-existing injury that is a risk factor that they carried in with them when the demands were placed upon them. And then in a repeated fashion, they needed to use their instrument repeatedly in a way that was exhaustive. It was tiring, it was inflaming. So with burnout, when people get enough rest from the repeated demands placed upon their instrument in the same way, the body's natural tendency is going to be to try to recover. And so Christoph addressed that really beautifully in talking about how in the beginning, one of our risk factors actually as a new professional in any sort of caring field is that we have an unbridled enthusiasm most of the time. We're very excited about what we've been learning for the last few years. We very much want to be of service. We are full of life force in our early life. We can think of no other better use for our lives. And here's an opportunity. I'm finally let loose in general population to use what I've been working on so hard and spending all my time and money and energy to develop. And so that raw life force gets let loose. And of course, the systems we go into love to take advantage of that and just milk it for what it's worth. And so we will work over long hours. We will go the extra mile. We will skip meals. We will get up early. We will do all sorts of things in order to please the people that we are working for and the people that we serve, and try to meet the unending demand in whatever field that we work in, whether it's teaching or medicine or mental health, any kind of a service industry. Once you enter it as an empathic person, you see the suffering and the unending sea of it, and you just want to do all that you can. And so burnout very often can resolve itself once some of that unbridled enthusiasm gets grounded with the hard realism of how much we can actually do in any one of our roles. And we're forced by the natural product of the year to go and take some vacation time, to take some holiday time. Just stepping back from the immediacy of the demand can often give us an opportunity to rest and reset. And so what happens is folks get into a rhythm where they know when they need to put a block of time in their year, in their month, in their week, in order to pull back and do some self-care in order to recalibrate and flush inflammation from the system and then re-engage. But what happens with compassion fatigue that sets it apart, it's like a repetitive stress injury that can't get enough rest and reset. And then there's a deleterious damage that continues to wear down to the point that rather than just being able to say, rest your tennis elbow from bagging the groceries, and then maybe adding a wrist guard of some sort to support you when you have to go back to work, now you have to go in there and do surgery and open space back up. And now you can't ever use that arm exactly the same way, or you're just going to be back where you were and faster and in a way that actually might have lifelong effects. So compassion fatigue, subjectively, the research suggests, is much more like PTSD for work. And it can have really long-term effects if it's not treated super effectively.
It also seems like it entails building emotional walls around yourself, because the suffering you're seeing, how much grief gets overwhelming. And this is not something that strictly happens because of individual traits. There are structural factors that contribute to burnout and compassion fatigue. And I know Matthew Cordova, he was one of the authors, along with Christoph, of a study published in the Mayo Clinic Proceedings in December about resilience training. And Matthew, I wonder if you can expand some more on the systemic elements of this issue, including a healthcare system that frankly emphasizes seeing a large volume of patients.
Yeah, thanks. And I think that the useful distinction that has been made is avoidable versus unavoidable factors that contribute to burnout. And we might think of the way our healthcare system is laid out, where people are being expected, as Christoph was describing, to work exceptional amounts of hours and really getting squeezed to be more and more efficient. The liability risk is high, so there's threat of doing it wrong, and what happens if you make a mistake, and a system that is really treating you more like an employee and in some ways like a widget maker, rather than somebody who's treating human beings. And as Karen and Christoph were saying, the people who enter these professions are very giving, altruistic, somewhat perfectionistic, super smart people who are trying to do their best and willing to do their best, but are in a system that there is no enough. And so what we see happens is people are trying to meet all those demands, and it's really an impossibility. And so they start experiencing the inevitable experiences that lead to burnout and compassion fatigue. The other thing that we sometimes think about is the cultural, the socialization about emotions. And I think we know our society does this in general, but so do medical settings and mental health settings, that despite the idea of wellness being something we all think, yeah, wellness is good, what often happens is that the professionals are taught, and this happens specifically in medicine, that their emotional reactions need to be compartmentalized. They need to have clinical distance. They need to somehow manage those separately or not have them. And so if they become distressed, which we're kind of describing is somewhat inevitable when you're working in a sick system, or when you're working with patients who are suffering and you're trying to be there and present for them, it's normal to be distressed. But if you have an internal metric that says, I'm not supposed to feel that, or that feeling is somehow wrong, or I'm supposed to tamp that down. And if you have been socialized to be externally focused and not to be aware of your own emotional experience, then it's a recipe for people, it's creeping up on people and then kind of stymieing them. And so a lot of the things that we think of as fixes have to do with increasing awareness, changing systems, but also teaching people to be more aware of their own reactions and engaging in some of the self-care and active approaches to managing those emotional reactions.
I'm glad you brought up culture, because it seems like it's not strictly the system in place, the pressures from the insurance company that doesn't give you a lot of leeway, or the hospital administrator who wants you to see more patients. It seems like there are some common denominators among a lot of the people who go into the healthcare field. They tend to be highly accomplished, they're driven, they have a mindset of self-reliance and resiliency. And it seems like seeking help maybe even creates a stigma among people who have that kind of drive. I think we see some of the beginnings of the genesis of the problem, and the cheap labor that residents turn out to be, because they're expected to work 80-hour weeks, and just tend to a number of patients that would not be normal under any conditions. So I wonder whether both you and Matt can, both Matt and Christoph can address the issue of culture. The idea that all these self-driven people are put in an environment where they're being asked to drive themselves even harder.
How do you want to start?
Christoph, you want to jump in?
Well, one thing that occurred to me listening to Matt just now is that, we've noticed many people have probably noticed it, but we've noticed teaching and working with healthcare people that there's a range, and there are people who are more psychologically minded, more interested, maybe very interested in emotional issues, relational issues, learning and teaching about that, and then folks that are totally uninterested. And one of the things that I was thinking about when Matt was talking is, as the time pressure has become so great, there's a parallel process that happens where if a patient is having an emotion, there's a sense of, I can't touch this because I don't have time. I don't want them to express their grief. I don't want to hear about their anxiety because I don't have time. And that also reflects how the physicians feel themselves. And so there's this sort of bi-directional agreement almost. I don't know, actually patients agree, that may not be fair, to not touch it. And I know a lot of the audience are healthcare people. You know, sometimes it's actually great to just be able to talk about it, right? If somebody's having an emotion, you can address it and talk about it and ask them about it. But when there's a sense of like, I can't touch it, meanwhile, it's like densely present in the room, that creates this sort of, it reinforces this sense of it's too big to touch, you know, I can't touch it, I can't talk about it. So that's a big piece. The other piece that I'll just mention is, to this day, you know, the year-to-year reprivileging process for a lot of physicians involves questions like, have you ever known, if I'm reprivileging Dr. Cordova, have you ever known him to have any mental or emotional or physical problems that would keep him from doing his job, right? So there are these what might seem like small, but they're very strong cues that I can't talk about it and I can't admit it because I may not be reprivileged, I may not be hired or rehired.
It seems that there's also a stigma toward about seeking help. It would seem like a natural thing to go to your superior, go to an experienced colleague and say, hey, you know, I'm dealing with these issues. You know, I'm overworked. Is that frowned upon in the profession?
Well, it's yes and no. I mean, I think, and I would love to hear Karen and Matt talk about this. So many physicians, nurses, mental health, counseling psychologists, clinical psychologists were raised taking care of other people, right? So their whole organizing, even unconsciously organizing principle is, I'm okay if you're okay. As long as you're okay, I can be regulated and relaxed. So to turn that lens around and say or take in, I am not okay on my own, and trying to take care of other people more isn't helping, is a really difficult like pivot. And so that cultural and psychological really conditioning is very, very hard to push back against, even if people are saying outwardly, please come talk to me.
Karen, you strike me as someone who actually doesn't have that kind of a issue, like, you know, like that you're comfortable reaching out and expressing how you feel. But have you seen that in the profession?
I would say that the mental health profession is probably one of the most infamously terrible populations to try to serve clinically. I have a therapist that I found when I was a trainee at age 24 who has a specialization in working with other clinicians. And she says they're the worst clients. There is so much stigma about self-care in any of the caring professions. And there still is a lot of internalized shame about being in some sort of a lineage of care. And I think that there is a lot of messaging in the mental health field as well as others that if you really understood this material, then you wouldn't need to have anybody do this with you in order to make sure you stay healthy. And so what I tell my students is, would you want to go to a dentist that doesn't floss their teeth? We all have to do certain things in order to preserve our youth and health as long as possible. And if we're doing a profession that we don't even believe in enough to engage in it ourselves, what are we telling our clients, right? If we think that seeking help is a sign of weakness, then what does that mean that we think about all of our clients fundamentally? And yet, if we treasure and appreciate mental health enough that we engage in the practices that are known to protect us over the course of our career, then we can actually have a really long, healthy career and be of meaningful service across our trajectory without becoming one of the positions of authority that is so hurt by the work of being a sensitive person in the suffering that we can't actually take care of the people that we're supposed to be leading along the way. And so I think that there is now there are enough decades of data to show what the healthy behaviors are that people need to engage in order to have a long, healthy career. But I don't think that there's a widespread understanding about that that's just sort of in the cultural fabric at this point. I think that people who have been harmed by the systems that they work in went seeking this information if they decided to stay in the field. And that has made it possible for them to get a work-life balance and do the personal care that makes it possible to have a meaningful long career. But I will just say I've reported to plenty of people and I've been in plenty of systems that are very compassion fatigued. And one of the reasons it's still a problem is that it trickles downhill. So if you are earning your livelihood by being a caregiver and you turn to a caregiver who's not able to really fulfill their duty to you, but they're not doing anything so illegal as to be considered impaired in such a way that a compassion fatigue system would actually do something about it, then there aren't that many places to turn. And I will say as a line staff and a person who's been in different kinds of positions in these systems, I have seen so many mental health people go home and drink wine in front of the TV by themselves, have no meaningful relationships outside of work in order to just downregulate the distress of the day in order to get up and do it again the next day, because they're just counting the days until retirement. And I think sadly, that's not very uncommon.
Yeah, it's certainly healthy.
Can I piggyback just a couple of things? So one, I wanted to just throw out that we all can identify the imposter syndrome piece of this. So that's another quality that people bring to their profession. We all know our own limitations. And so if we are privately concerned that we might not measure up, then actually admitting I'm distressed or struggling, there's some extra weight with that. The other thing that has been really well written about, people have described this experience that Karen was just talking about as a broken covenant between themselves or their profession and the institutions they work in. In other words, I'm going to bring my full self and I'm going to do everything I can, but then the profession I've committed myself to doesn't back me up, or the systems I work for don't take care of me. And the other verbiage has been around moral injury. That this idea of moral injury is either somebody that you respect and count on not living up to the ideals that have been agreed to, or you yourself. And I think that these experiences are morally injurious, to work in systems and give your all to a system and not feel that it has your back. And then Christoph, when you were talking about that thought came to mind, like looking at yourself saying, I don't like how I'm feeling about my work. I don't like how I'm feeling about my clients. I don't like how I'm not living up to my own ideals. And that contributes too. And then I'll stop in a sec, but I wanted to, Karen was also saying that sense of, if you understood this, you wouldn't need this. Like if you understood the tools of your profession, as if we as human beings are somehow not going to feel distressed. And we would, I love Karen's metaphor for repetitive stress. I mean, if you took a hammer and hammered and hammered and hammered, eventually the hammer wears out. And how could it be any different? So the idea that one of our focus groups that Christoph and I did, one of the students said that they really resonated with the idea of, it's like a professional athlete who needs to do daily stretching and work with a trainer and eat right. And like, this isn't a deficit to have these emotional reactions. It's normal. It's how human beings respond to chronic stress. And so the idea that we need to change our culture around it to make it okay to recognize, admit to, and attend to, that's a big piece of this.
I just want to jump in there and say that that's the emotional Olympics, right? That so many people in the caring professions are training in constantly without necessarily commensurate support. And that's where you see people breaking down.
Matt had mentioned the feeling of not measuring up. And I was thinking about what so many of the healthcare workers have dealt with during COVID, as we've seen more than 100,000 Americans die, how many of them had dealt with that, the grief of their families, and the helplessness of not being able to help to keep those people alive. I imagine there's a feeling of failure among people in the profession when that happens. And Christoph, you and I briefly touched on it a little bit. I was hoping you could address a little bit more. What has it been like, you think, for people in the healthcare profession as they've dealt with this pandemic and the huge failures of the system in the United States? We have by far the most deaths and the most cases in the world. And how have people in the profession dealt with it?
Yeah, thanks. Such a good question. Back in April, I was trying to get really understand what was going on, because just to say it deserves saying that the Bay Area and San Francisco has done anywhere between very and exceptionally well with COVID, just to say that. But in the early parts of the pandemic, I was trying to put these support groups together, and I wanted to talk to people who were in New York and in New Orleans. And I didn't know people, but I had friends who had friends. So I spoke to two handfuls of people who were working in the hospitals. And Matt and I wrote a piece about this. There's really a couple essential things that I think relay it. There's sort of, you could argue that there are three things that physicians do, essentially. The first thing that they want to do is they want to help and treat and heal people. And I think we can all recall that for months and months, there wasn't a single treatment for COVID. And even now with remdesivir and dexamethasone, there are some treatments, but many, many, many people were coming in and dying, and there was nothing to do about it, which is pretty uncommon, a very uncommon situation to be in. So that was number one. So that was sort of, you could say, taken away as an identity. I help people. So if they can't help people, they like to be with people, be with them, talk to them, understand, support them. Well, there was no way to do that. We all had this layers of protective gear. One thing I've known personally is that to don and doff the gear to go into a room is a major pain in the butt, and people will do anything not to do that. So even just contacting a patient is suddenly there's layers and layers of difficulty. So then when those things fail, when all that fails, the third thing is trying to orient the family to what's happening, the dying process. And of course, that was impossible as well. The best that many physicians could do would be on the phone. Many of the hospitals, especially early on, the physicians just couldn't do it. They didn't have the time. So other people were given that job. So these sort of incredibly essential elements and both the function and the identity of physicians were just totally kneecapped, really. And it was brutal for them. And then just to add that some novel things, for the first time, people were being furloughed. They were being forced to take vacations. They were being outright fired because of the income problems with closing down. And a lot of healthcare people felt like they couldn't even go home because they'd infect their families. And then just to top it all off, the sheer volume takes everything and exponentially turns it up. Yeah, so those were all really unique and sort of, in terms of meaning, very powerful insults, I guess you could say, or challenges for physicians and nurses and really everyone in healthcare.
We know about these heartbreaking stories of nurses or perhaps doctors who have been holding up iPads for the patients to say their final to their relatives, because their relatives can't be in the room. And sometimes the doctor or the nurse, they're crying, as they're listening to all the other people involved crying. So it's just absolutely wrenching. I wanted to move on to the impact of burnout and compassion fatigue, and how it impacts the patients and their relatives. And is it because they don't get adequate care? Is it because they feel like they don't get the sympathy they deserve? And Karen, can you address that?
Sure. So some of the behavioral symptoms of compassion fatigue are very quantifiable: absenteeism, lower productivity ratios, longer turnaround time on phone calls and emails. All of that sort of data tracking is really clearly well established. And then there are some more subjective sort of qualitative components of compassion fatigue that are experienced on the hand of the recipient of the service. And what that might be experienced like is a lack of sensitivity. And it might show up in a lot of different ways depending on the constitution of the practitioner. There can be a tendency towards being short-tempered, impatient, this learned helplessness of being able to do anything and therefore just disconnecting, or anxiety in managing the demands that are being placed on the practitioner. And so then you might see some management of the practitioner trying to contain what is being asked of them in order that they can organize what they need to do and prioritize it. And so it's not uncommon when people are really far along down the road, they will just disappear. I mean, people will leave charts and go away, leave a country. I mean, people will do all sorts of things when they're really far along. Before people get to that point, they're often experiencing being micromanaged by their system because the system isn't necessarily noticing their distress that they're feeling, but they're coming for their paperwork, they're coming for their productivity ratio. And there gets to be this really problematic feedback loop where your patients are complaining about you, your clients are wanting to switch to a different provider. They're saying that you haven't called them back. And so there are the real breaches, ethical breaches and legal breaches that can happen. And in the lead up to that, there will be signs that the practitioner just can't quite handle what you have to say or what you need. And there will be what in the clinical world are therapeutic misattunements, these little ruptures that happen in the relationship that just get to a point that it gets too hard to repair. So when people are really balanced and their work-life balance is good, the sensitivity will show up in repairs of ruptures and avoiding ruptures in the first place. But that just gets harder and harder to do the further along people get. And so I'm sure that patient complaints and dropout rates and lack of adhesion are going to be some of your most obvious measures. And I think as the research continues to develop, we will see more nuanced indicators, pink flags, before the red flags really start to show.
Not only are the patients getting harmed by the issues related to burnout and compassion fatigue, the system itself is strained because healthcare workers are not at their best under these conditions, and it has led to a high rate of suicide. The healthcare workers, physicians in particular, they have about twice as high a suicide rate as the general population. And female doctors have an even higher rate than that. I think we're familiar with the case of Lorna Breen, the young doctor in New York City who was dealing with COVID patients, and she was overwhelmed and committed suicide. And this brought to the national attention the issue of suicide in the healthcare profession. There's one more topic I wanted to bring up that Christoph talked about for a moment, as far as the issue of money and the pressure to earn a lot of money. I think there's an impression among a lot of the general public that doctors are all wealthy. They all make a ton of money. But as Christoph mentioned, he didn't have to deal with big student loans when he finished med school, but a lot of his colleagues did. Matt, I wonder whether you were one of them, and if you did, whether how you dealt with that, or if you didn't, if you know people who encounter that problem and how did that impact them? Because there is a big financial pressure on doctors to put in a lot of hours and, clear that student debt.
Well, I mean, I'll say, I think that is an issue where a lot of people are feeling pressured to continue into a profession, doing whatever it takes to succeed, because financially they're up against it. I wanted to maybe add to that. One of the questions it looked like came up in the chat was pointing out the disproportionate effect on providers of color and a combination of things, right? So there's discrimination that happens within healthcare systems. There's also healthcare providers that maybe come from disadvantaged backgrounds that already are coming into the profession with fewer resources and maybe less family support and so are feeling greater pressure. And then we've also watched the disproportionate impact of COVID and on the existing health disparities that happen to begin with. So we know that people of color in our country, their life expectancy, their access to care, the kinds of care that they receive differs, and then to see COVID playing out differently, and some of the broader structural and systemic issues happening in our country is another kind of moral injury and another kind of pressure.
Karen, this is something you've dealt with quite a bit, right? Because you've had a lot of experience with immigrant communities.
My clinical work is focused on migrant families, Spanish speaking. And part of what we are talking about here from the lens of traumatology is the pervasive ongoing type 3 trauma being targeted for an identifiable characteristic that makes one feel generally unsafe in the world and needing to have a certain degree of hypervigilance just to get through the day. And then when you look at somebody who is a person of color working in a system that is got dismissive tendencies, there isn't always a safe place to go with that kind of type 3 pervasive daily trauma being expressed by patients that one is in a position of taking care of, being expressed by coworkers that one would be turning to for some kind of moral support, being demonstrated in the world at large with ongoing murders. It doesn't feel like there's a safe harbor anywhere. And so one gets to start to feel very much like a human resource that's just being mined and used for other purposes without really gaining anything back from any of the systems one is interfacing in. And so where we look at compassion fatigue being like PTSD for work, that's a combination of relational and developmental traumas that get stacked on with subsequent shock traumas. And that's a lot of what's going on for doctors right now, dealing with this global crisis that's lasted for over a year. And then when you compound that with the type 3 trauma of systematic racism and no real way to get relief from that, that is an absolute recipe for suffering.
So we have outlined the problems we're dealing with. In the 11 minutes or so we have left before the Q&A, I'd like to take a look at possible solutions and prevention. Christoph, you made a passing mention about how you encountered your own issues and what you did about them. I was wondering if you could lead us in that discussion as far as what would be the ways to address them, and then we'll get into prevention as well.
Yeah, so when I was training to go to be a psychotherapist, my experience over and over was during the classroom and clinical training. I would learn things and just have this strong reaction of like, why did I not learn this in medical school? Why did I not learn this in residency? It just happened over and over. And the things that I found helpful in my own therapy lined up with when we did a number of focus groups 4 or 5 years ago with residents and asked them what stressed them out and what caught them. And then clients of mine who were nurses or physicians, these things were just had a huge amount of resonance and the same themes kept coming up. And so, this article that Matt and I wrote, and Dr. Osterberg from the VA proposes a sort of an approach, and this is more along the education and prevention standpoint. I know Karen's going to talk about some of the treatment, which is a way to look at resilience as having certain levels. So it starts with what we call sort of a foundational skills or practices. So meditation, compassion practice, healthy behaviors, eating, exercise, sleeping, cognitive reframing, things that really help on a foundational level people be in their body and relaxed and aware. And you can imagine, if you think of physicians or nurses or mental health people, early on, you would want to start with those foundational skills. And then the next layer we kind of frame as intrapersonal skills, things we do in our own body, mind, primarily emotion regulation and stress regulation. Now you could say that in order to know that I have an emotion to regulate, I might benefit from some meditation to actually be in my body and be aware, wow, I'm really angry. This patient is really making me angry. So these intrapersonal stress and emotion regulation skills sort of, in a way, sit on top of the foundational skills. And then interpersonal skills, a lot of physicians are not good at conflict. There are exceptions, but most physicians and nurses, and I think therapists, really, really do not like conflict. And so how to have boundaries, how to approach conflict consciously, how to de-escalate, how to do motivational interviewing and sort of give some authority and autonomy to the patient or client. These are things that are critical for people to know how to negotiate all of their relationships with their colleagues and with their patients. And it goes on to teams and systems. But the idea is that it's almost like deconstructing therapy. The kinds of things that people who burn out often need to learn in therapy can be pulled out and taught ahead of time to students and to residents and to physicians who can then take some of this in and be more resilient, if that's the word, and hopefully burn out less.
And of course, it's always better to prevent the problem than to have to treat it. And Matt, you and Christoph worked on this study together that was published in the Mayo Clinic Proceedings. And I wanted to ask you how big a component of addressing this should be education. Should it start even before med school at the pre-med level? Should it continue through the career? How much focus should there be on prevention instead of treating the problem once it's there?
Yeah, I think, and we've been laughing, this, I think it can start, we know kindergarten and preschool classes that have kids starting doing meditation and emotional awareness training that teachers do in their classrooms, those things, and those are the kinds of things that probably help validate and normalize that there is a whole host of internal experiences that are okay to have, and being aware of them and having the tools to self-reflect are probably important societally for us to be, embracing. But yes, in education, we've been talking about and trying to implement having these things very early on. Pre-med, as you said, we know that for professions that are known high-risk professions, first responders in the military, there are things like, we know you're going to go into experiencing a great deal of stress and demand. Let's equip you. The education part of that, the actual knowledge is part of it, but the experiential part is the other. So of course, we've all had that. You can read something and it hits one way, but doing it and feeling it is different. And so I think one of the things that we've appreciated talking with Karen so much about recently is really kind of the very micro levels of self-awareness that are that can be taught and trained, but they have to happen experientially. It can't just be book learning. It has to be the doing of it. And then, as Christoph was saying, it can't be one-off, right? For none of us learn something and say, oh, that's it. I'm now resilient. Resilience is an ongoing process. And so it has to be something that is nurtured and continued through a career. And that's also part of that developmental model, and getting in with foundational skills.
And I would just add super quick before Karen talks, the beautiful thing that we're seeing is that there's as we move to younger and younger generations, there's just more and more openness to these ideas. They're less stigmatized. They're more, they've had therapists in school, or their brothers or their sisters or their parents. And so it's opening up. And in resilience in healthcare, this company, we're trying to encourage and give these skills to different people at different medical schools and different groups and practices, so they can sort of start to pass it on and have people learn some of these skills, physicians or nurses or people who have, what's the word? They already have the skills. They already have a natural proclivity, so that they can then teach them in their institutions.
And Karen, for those healthcare workers who haven't had the benefit of that education as they were going through pre-med school or med school, and particularly some of them who might be older and more set in their ways, what are the treatments that you would suggest to address these?
So we will share some resources with everybody when we send the link out. We will share a lot of resources with you, including some PowerPoint slides on compassion satisfaction. There are some formulas available for what needs to happen, and essentially to resolve the stored charges of overwhelm that were implanted at work, we basically need to do bottom-up trauma intervention work in order to resolve those charges as they're stored in the nervous system, in the brain, in the cells, in the muscles, and in the thought process as we re-engage with work. And so I would encourage practitioners to be looking for a licensed clinician who is trained in a bottom-up modality. I'm not here to say which is the right one. I could include on the list that we send out with you some suggestions for you to explore. I would say that there are components of the client's constitution and the goodness of fit with their clinician that is going to really predict how effective a particular bottom-up approach will be. But this is not something that just gets cognitively reorganized and then it's done. Trauma really lives in the body. All of the trauma research shows that it needs to be resolved in the body in order for the brain to start receiving different signals from the body. And so there are lots of ways to help people safely come into their body and the overwhelm that is still there, and start to systematically discharge it in a way that is contained and regulated and digestible, so that somebody doesn't get re-traumatized. And that's what trauma counseling is all about, is really being organized about carefully going in to resolve just a little bit at a time what can be digested.
Okay, great. So I think we have several eager participants who have sent us some questions. So let me start with one I found particularly interesting, and whether and I'll throw it out to the group, and maybe one of you can take it. I don't think we should have all three answer the same questions, because it would leave us less time for other careers. But let me throw this one out. Can you speak to how to work with physicians who may be struggling with compassion fatigue or burnout in therapy? Who'd like to tackle that?
Not everybody at once.
Do you want that one, Christoph?
I think you're welcome to take that. You're welcome to take that if you're moved to. The question was how to work with physicians with compassion fatigue in psychotherapy. Was that the question?
Can you speak to how to work with physicians who may be struggling with compassion fatigue or burnout in therapy?
Okay.
I can start that, and then if you want to add, Christoph. So clinically, compassion fatigue is PTSD for work. And so we basically use a PTSD approach, and different clinicians have different ways that they've been trained to do that. As someone who's been trained somatically, I do a lot of sensory awareness work to create a safe container for finding comfort as a starting place, and really focusing on what provides safety and stabilization for the client in the beginning. Once we know that the client has easy access to safety and stability within and anchoring their attention in the here and now, then we will pick a piece of overwhelm to discharge in that session. And we do just one piece, and we spend about 20 minutes on it. And there will be some narrative processing to create a coherent narrative around that on the time frame. And then with different modalities I'm trained in, we will work to unravel how that particular overwhelm got grafted onto earlier developmental states that really activate a sense of vulnerability and lack of control and lack of ability to re-engage in a way that feels regulating with people who provide security. And we will work that through. And then the last 20 minutes of session will be to really anchor and ground that, to integrate it with a week off and a little bit of check-in in between sessions about how the rest of the self-care plan is going. And so working that self-care plan, there are formulas out there for what needs to be done. And that would be something else I'd be looking for with my clinician, is how they integrate the self-care homework between sessions to make sure that every bit of activation that is coming up is actually integrating out.
So here's a question that I think will be well suited for Matt to answer. What can organizations do to reduce compassion fatigue and burnout among their staff?
Well, I think part of it's going to be naming it and recognizing it and recognizing that retention is built on having people that are emotionally and physically well. So that I think if institutions are interested in money, that being able to kind of help them recognize that in the long run, not burning out your staff and keeping people healthy and in the profession is going to be good for your employees. It's also going to be good for your clients, because as we were talking about, it's going to reduce the number of medical errors. It's going to have people, we know that burnout is associated with poorer patient adherence. So you're going to have your clients are going to get healthier if your doctors and healthcare providers are healthier. So part of it is labeling and embracing that. And then the other is making some structural changes. And I don't want to put it in his lap, but Christoph has been kind of trying to work in the settings he's working in. How do you have things like peer support, groups that physicians can turn to talk about? How can you destigmatize and have it be okay to say, hey, I need some help, or this is what I'm experiencing? So I don't know if you want to pick up.
Yeah, I would love to just underline that. So one way to think about it in resilience in healthcare, what we try to provide are two things that, like, you could think of them as modules. Like if you have a chance to talk about boundaries, then people start to think about boundaries, right? If you talk about emotion regulation in a way that's accessible and not too much, then people start thinking about it and they start talking about it. And I'll come back to that. There are also processes. So two of the processes that I would highly recommend considering there's something called Balent groups, and we could spend a lot of time talking about it. But they're tailor-made for healthcare people to discuss difficult cases, but not cases that are medically difficult, but relationally or emotionally difficult. And they're specifically designed to be safe for people who aren't, teaching psychology to talk about things. So that's a process that I've seen when half of a practice does it changes the whole field of the practice, because just like if a few people are really burnt out, it can really change the feel of the whole group. When several people are talking about these things, that can change the group field in a very positive way. And then what Matt mentioned, which is peer-to-peer counseling, peer-to-peer support, teaching people in a group how to be there for other people without fixing them, criticizing them, advising them, judging them. That's a whole other thing, other field that can be really, really powerful in a group or a practice.
Can I
That
mention?
also be a way to, I'm sorry, Matt, there's a question that asks about dealing with feelings of embarrassment about admitting that you're dealing with this problem, and I'm wondering whether that would be also a way to address that, and particularly for people, you guys can both talk about it, but I don't know, Christoph endured the problem. Did you go through feelings of embarrassment about having this, and if so, how do you deal with them?
So yes, I did. I went through embarrassment. I went through deep shame that why can't I do this? Why can't I handle this? What's interesting though, is since I was in the last 20 years, the pervasiveness and the prevalence of the problem has just expanded immensely. And so 20 years ago, if somebody was having a problem, it would be easier to say, well, that's Gimler's problem, but the majority of healthcare providers now have either moderate or significant levels of burnout. And so what I try to get people to understand is if they start talking about it, which is hard, I'm not saying it's easier said than done, they start sharing it, they'll start to realize how extraordinarily pervasive it is. And maybe some people are a little bit more, a little bit less, often depending on how long they've been practicing. But that embarrassment is very understandable. Everybody feels it. And if you can lean into it and find people, you can usually sense who's maybe sort of safe, who's safe, like maybe a colleague, administrative, clinical, anybody. If you start with what feels safe, you'll start to feel how extraordinarily common these issues are.
Karen, maybe you can take this one. One of our participants writes in saying, I find I'm able to be present with my clients, yet struggle to manage conflict with non-clinical co-workers, in a school-based setting. For those of us who work in settings with non-health, mental health colleagues, how can we better communicate our need for boundaries and the complexity of our professional identity?
My short answer is that gets easier with practice. My longer answer is that is a huge supervisory issue early on in the career, to get support from exactly what Christoph is saying, safe mentors in your agencies, about how to navigate the various different expectations that are placed upon you as a professional in your role. And very often what especially trainees and interns find when they launch is that previous trainees and interns created unhelpful expectations for you because they've bled their boundaries, they've made mistakes, they've accidentally been too forthcoming or not careful with their boundaries. And in the effort to create collegiality and teamwork and get support somewhere where they can, they have made a mess for you to clean up, in the sense that you're not actually allowed to blur those boundaries very much in your professional role. And so you find yourself having to correct expectations that were created before you got there. And what's helpful to do that is to actually have exactly what Christoph is talking about, this moral support in the safety of your home agency, where you can come back and say, that teacher came at me again, and I really want to be polite and patient, but I just don't know how to manage this particular one. Can you all help me? And to workshop these really granular kinds of stressors that happen, professional challenges day by day by day that can wear at you, and therefore equip you to go back into the school the next day or the next week and say, I'm so sorry, I can't help you with that. I would lose my license and my supervisor's license if I told you that. And I'm so sorry, I'm not at liberty to do that, but I would like to help in other ways. And this is what I can do. So that you constantly have this sort of self-protective response in your back pocket as you deal with the daily stressors. And this is the kind of thing that erodes when there isn't good morale at work. People don't feel safe to come back and say, I have a need. And this is one of the pieces that Christoph and Matt are both working very actively to try to fix at a systematic level nationally in medical training. And I do believe that the field of mental health is trying to do something similar as we increase the conversation about the complexities of the work and how that wears at your general sense of well-being. But the key component in mental health is having a supervisor that you can turn to. And what I tell my students is if your supervisor isn't that person, everyone in the agency knows who the safe people are. So you just want to ask, who are the safe people here? And every supervisor that is still healthy enough to see the need will be responsive when someone who's not assigned to them is coming for some extra consultation as part of their ethical due diligence to be able to manage all of these complex demands that are placed upon you daily.
And if I could just add, I totally agree with what Karen said. I actually worked at an elementary school as a therapist for 3 years, 2 days a week. And a lot of therapists, a lot of physicians aren't good at setting boundaries. And so like Karen said, I learned that there were 8 or 10 supervisors in my agency. I had to ask certain people, like certain people couldn't help me. If I asked, how do I set a boundary? They couldn't help me. And then a couple could. And so you just keep asking until you find the people that can address it. And to even think of it as a skill I need to learn is how to set a boundary is beautiful. It's beautiful to even have that frame.
We have time for a couple more questions. Matt, this one's for you. In some research for a class project on the stress of COVID on healthcare workers, I found that nurses express more symptoms of psychological distress, and yet it sounds like suicide rates of doctors may be higher. Do you think that's a correct interpretation?
It's a great question, and my initial thought is expressing symptoms of distress is probably a good thing when you're in a system that is distressing, and maybe not being aware of those symptoms is part of what contributes to kind of the pressure and desperation that would lead somebody to die by suicide. But so the other thing is that nurses in most healthcare settings are the frontest of the frontline people, right? They are hands-on. They are the people that patients disclose to in the waiting room as they're getting their blood pressure taken, and personally, and they also have, nursing professions have more psychosocial spiritual training integrated into that profession, maybe traditionally more than traditional medical education. So they're probably quite in touch and also hearing and connecting in a way that is more organic with patients.
Okay, and Christoph, this one's addressed to you. It says, how often is moral injury or moral distress the backdrop for burnout? It says, Dr. Gimler seems to have experienced the basic factors that contribute to moral distress, not being able to provide the care needed because of the incursion of profit orientation.
To be totally honest, the frame of moral injury is fairly recent. It's something that I've learned about and digested sort of over the last, let's say, 3 years. But it definitely resonates with me. I think it just resonates in a slightly different way of just being so clear. I forget the phrase Karen used earlier. The systems are just broken. And, you can frame it in different ways. You can frame it as the system is broken and creating moral distress. For me, that's true. That's true. I think, I hesitate to say this, but starting to see that the system is broken is really important because so many of us have this unconscious belief that the system somehow should be healthy, right? And whether it's a teaching institution or a healthcare institution or a family institution that ends up having significant dysfunction, to really start to see it clearly is so important. So I hope that answers the question.
Well, just because that's about all the time we have today. It's almost 1:15, the time of our conclusion. I wanted to thank all the participants for joining us today, and especially thank all our panelists for a very informative discussion. A recording of today's webinar will be emailed to everyone in a few days. You can also find it and other webinars on Palo Alto University's YouTube channel. If you have further questions, feel free to email externalaffairs@paloaltou.edu. Thank you so much for a very enlightening discussion.